Good afternoon and welcome to Taking Your Ambulatory Sites to Stage 7, a complimentary webinar from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I'm the Editor-in-Chief of healthsystemcio.com and I'll be your moderator today. Regarding questions, we do encourage them. Feel free to type them into the lower right-hand corner of your screen into the Q&A box at any time. Leave the default set to all panelists and go ahead and send those in. We'll be looking at those and posing them later in the program, but you can go ahead and send them in at any time. Downloading the deck is easy. You've got the URL in front of you. It's a shortened URL at the bottom of all slides, and I'll send the URL out in the chat box as well, so don't worry, you'll get plenty of chances to grab it. And we are recording today's event, so you can go ahead and you'll get an email when our archive is ready and a separate registration is required. So you see how we're going to spend our time today. We're going to go about 40 minutes. First, we're going to hear from Dennis LaRue, SVP for IT Planning and CIO at Rockford Health System, and then we're going to have our Q&A with Dennis. So without further delay, I'm going to turn it over to Dennis LaRue. Dennis, thanks for joining us today.
Thank you, Anthony. Good morning, everyone. I am very excited to share with you some of our successes with having met the Stage 7 requirements. We met the Stage 7 audit before the end of last year, and we're about to receive the certificate, I guess, at the HIMSS conference in April. But in any case, this discussion this morning is not so much a roadmap of the criteria necessary for the ambulatory stages of Stage 7, but more of a discussion about setting up the environment for success, particularly with physicians and providers, that lead to the ability to meet most of the criteria set forth by HIMSS Analytics. There are some criteria, for example, like device integration, that doesn't really require physician involvement, but when you get to the foundation on which everything resides, provider involvement, provider success is basically the foundation that we want to focus on. So that's what I'd like to accomplish today, and let's see if we can drive this. The requisite description of who we are. We're Rockford Health System. We're right on we're in northern Illinois, in Rockford, about 20 miles from the Wisconsin border. We are one large hospital of 396 beds. We have about 140 physicians that work under our employ, and we have several remote clinic sites around the area, which we provide not just primary care, but specialty care. A note of interest, we recently merged with an organization in Wisconsin called Mercy Janesville. In Janesville, Wisconsin. That deal actually was consummated on January 1st. We don't even have a new name for our organization yet. That might be decided at the end of March, but I'm basically describing the events that took place at our Rockford Health System prior to said merger, and all my notes reflect that process. So perhaps we'll have a different story to tell at a later date. They also have an EMR, and we're simply going through integration planning right now. We're proud of our mission, superior care every day for all of our patients. We have received numerous awards for quality over the years. And of course, I like to point out that we received the Most Wired Award in recognition in 2014. We've been able to attain EPIC's Good Install and Good Maintenance programs for the following a prescribed series of events, I guess, with them. But we also have HIMSS Analytics, and on top of meaning for use, rounds off what I can brag about from the position of CIO. So when did this journey begin? It actually started at a medical executive committee dinner in October of 2007, when I was challenged by physicians that we should have an EMR. And back then, we did have an EMR. It was a homegrown EMR by Gartner definition, was a level 1. It included a lot of information, including transcribed dictated reports. But it held lab results, radiology results. It did not have PACS images at the time, but it did have one. But at that MEC dinner, physicians indicated that they would attempt or like to see a more sophisticated EMR. And it was an interesting discussion because when I said that we had mostly everything, but with the exception of direct input by physicians, they didn't seem to back away from their statement. And so the idea was kind of germinated at that session. We finally went to the board in September 2008, and we had a presentation to the board called In Pursuit of the EMR, and we talked about all of this, the existing EMR, what could we do in terms of a new one, what kinds of options were available, and the like. We were delegated to go off and evaluate a number of different options, for which we did evaluate just like 10 different options from all vendors. And when I sat down from that presentation, I indicated that I had not evaluated one particular vendor. And they said, why not? And I said, I didn't want to lust after something we couldn't afford. And they said, you looked at everything else, why not look at this? And so we did. So we ended up coming back to the board in September 2009 and talked about all those options and actually made a recommendation that led to a decision to look for an integrated record. And you see the slide there. We did decide on the EPIC platform, and in April 2010, I basically had a budget approved to proceed. The journey started with a phased approach. The object of our discussion today is on the ambulatory side, but we had that approval again for phase 1 implementation. It came in April 2010, and we decided that we would bring up the ambulatory EMR over the course of 3 separate segments. You'll see later on why I talk about those 3. But in April 2011, we had our first group, primarily primary care docs, go live. And then we brought a second group of ambulatory physicians, a second group of specialists, including OB, in June 2011. And we brought out the remaining specialists live in October 2011. What you see there along this timeline was our journey, including the hospital implementation, for which we do not yet have level 7 attainment because of blood bank administration and imaging, which we're working on. We hope to go to that sometime in 2015. I don't want this to sound like it's a high school term paper, but in terms of trying to chase down HIMSS Analytics 7, I think it starts with the inception of the project. Everyone needs to know what we're doing. Everyone has to know why we're doing it. People should have an understanding of when we're doing it and what are the established target timelines, when do we deviate from those timelines, those kinds of things. We need to understand how we're going to do it, and we need to understand where it's going to be done. Now, the what, why, when, how, and where, outline, again, it seems like it might be from 8th grade. But when you follow this outline relative to communication with your providers, I think it serves a necessary purpose. So when we talked about what, we want an electronic medical record. it has to be patient-focused. That was one of our criteria. We wanted it to be comprehensive and integrated. Well, integrated, the introduction on the ambulatory side was meant to be an introduction for the total integrated product through the hospital at a later time. It needs to be secure, it needs to be safe, it needs to be easy. Well, what does easy mean? There's a lot of literature these days about all EMRs, most EMRs not designed adequately, and there's a lot of provider backlash or blowback in terms of the ease of use. I think that in its design, easy is a very subjective term that needs to be discussed. And what I tried to do was establish the facts around whether it would be easy or not. And basically, I told them it would not be. And I basically told them the EMR would not save them time, but I'll get into that in a few minutes. EMR functionality, what did we want within the function of the EMR? Obviously, we wanted results reporting. Everybody wants that. We wanted CPOE or med ordering, not just med ordering, but non-med ordering as well. We wanted a way to be able to have physicians electronically order these things. These seem to be mundane, but the rubber hits the road when we talk about electronic documentation. You know, can we get their dictating machines sighted? How do we do electronic documentation? We made a big argument that we didn't want to change the way they practice medicine. We wanted to change the way they documented the medicine that they practice. And so we were looking for these things in an EMR. We tried to establish why we were doing this. Well, you know, it was requested, as I said, from our physician group. But we also thought that it was a strategic move in light of back then the notion that we'd have the ACA and maybe medicine was finally going to work on a different paradigm. And so we thought that it would be transformational organizationally, and I'll get into that in a minute. It was mandated by definition of meaning for use, and a lot of organizations said, well, we're doing this for meaning for use in order to get incentive money. But I think a lot of organizations perhaps did not really focus on the fact that, yes, you might get incentive money, and a lot of people do want that. But if you do nothing and you keep waiting, there was a prospect of penalty at the end of the road. And so we did use that mandated as one of the reasons why we had to do it. And there was a lot of talk about ICD-10. As it is, you know, there's been several delays, but we wanted to try to get ahead of this transformation. Before ICD-10, we had to deal with it. And so that was also one of the motivators, if you will, or one of the reasons why we got involved. Now, this slide, you know, when you start peeling the onion and begin trying to put a little bit more meat around the whys, this almost sounds kind of like a vendor presentation about all the things that you're going to get out of it. But we wanted the integration, as I said. We wanted prompt, simultaneous presentation and communication. These are things that we wanted to emphasize with our physicians. We wanted to improve accuracy and completeness of clinical documentation. There was a lot of noise around that, and well, I can't tell this, if I don't dictate, I can't tell the story. And we went through a couple of iterations with that. It hopefully improves reimbursement and reduces denials. And certainly CMS has said that the introduction of EMR, they keep saying that we've upped the reimbursement. And I think, you know, it's not fraud, obviously, it's just that we're documenting better, in my opinion. We wanted to reduce malpractice premiums. We wanted to enhance the ability to measure and report outcomes data. We wanted to do that automatically. We wanted to achieve and maintain accreditation, obviously. And we wanted to improve clinical outcomes. We want to improve patient care. We wanted to lower the probability of medical error. Everybody wants these things, right? we wanted to be able to tell our community that we were an organization that was at the cutting edge of technology, so we wanted to enhance our reputation in the community for investing in a sophisticated tool like this. We wanted to facilitate physician recruitment. Certainly in 2010-11, as we were recruiting physicians from the bigger cities, many of them asked whether we had an electronic medical record, and we thought we could leverage our investment in that way as well. We wanted to improve operational efficiency. I can show you some proof that we've done that. Workflow, better educate our patients, improve quality of the care delivered. This is the basis for the reasons why we wanted to do this, and I think everybody would agree that that's the case. So when we talk about when, this is just one slide of many tools that we use in terms of implementation timelines. But the more important here is this. I don't know if you guys can see the cursor, but the Epic Care Ambulatory timeline, where we had established some benchmarks along our continuum leading up to the 3 specific dates that I outlined earlier. But one of the things about the timeline that I don't have an illustration of, but one thing that I brought to our docs is that if it takes T equals, pick any number, say it takes 45 minutes to see a patient, or it takes 3 hours to care for a patient from scheduling registration, actually seeing the doc and all the post work. I went to the doc and said, look, if it takes 40 minutes to do that, and right now you invest 10 minutes of your time to do it, this will probably require more of your time. Pick a number, say 20 minutes. So you've doubled the time it's going to take you, but we reduced the total time of care for the patient. So this is very patient-oriented, patient-focused. An investment in your time will eventually reduce the amount of time that a patient needs to invest in their care, and will provide peripheral benefit once we are able to digitize and use information to improve operations, improve patient safety, and improve patient service. So, but this slide relates to the fact that we have to make everyone understand when things are going to be done. We have several clinics across our organization around towns around Rockford, including our main campus. Our main remote campus is Perryville. And what I did is we cut all the, this is a matrix of all of our physicians by their specialty and where they resided. And we use this also as a map and a timeline in a way to illustrate where the group 1 docs would be residing, where we would need help as we stepped up to every one of these physician groups. And this served a pretty decent purpose in terms of planning device, also in terms of providing the physicians and administration a status report of what we're doing. I encourage everyone to try to cut this in this way. You need to understand how many specialists you have in the sequence of events and where, if there are any issues, where they might be. We were also able to develop some metrics around the performance of these organizations, not just by docs, but by facility, to see what might be different about that. As I talk about later, when we talk about after visit summaries, some facilities had layouts that were more accommodating to the way we wanted to issue AVSs to our patients as they were leaving the offices. Met somebody yesterday at Epic that talked about putting a printer in every exam room. We did not do that. I didn't want to do that, and we didn't do that. So that's what I'm talking about there. Expected returns. We use the Centera model that Bert Reese put together and presented in several forums, I think at Chime and HIMSS as well. And we extrapolated that information and came up with about an $11 million possible save in this fashion. We tried to relate this in our communication as well. What's interesting is we just had our quality department talk about reduced ADEs. They just updated this number, and that new number for us is anywhere between $3 and $7 million based on some factual information that we've been able to pull down. But it's important to try to get a handle in terms of the ROI. Now, when we talk, when John Glasser talks about that, you can't calculate ROI, it's return on information as opposed to return on investment. That's all true, but we have many boards that want to see some numbers. And right now, on that $11 million, I believe I can actually document, a real save of about $7 million against that 11, and that's important for the communication as well. We want to talk about transformation. We came up with a transformational top 10 list, and we documented this, and we put it in our elevators. We put it in a physician newsletter. We gave it to all the clinics, clinic staff, and these are the kinds of things that we talked about. We talked about 2 items of standardized care, and we talked about paperless twice. Well, paperless is one of the criteria that is looked up at when the HIMSS analytics team comes through your facility. They look for paper, and if they find it, they want to know why you have it. But we've tried to promote a paperless environment, and I think we're quite successful with having done that so far. Expected performance measures. Of course, we had the MU requirements. Everybody probably can see a level 7 guideline if you go to HIMSS Analytics. We tried to measure the rate of AVS as only one metric within the MU requirements, for example. CPOE is measured. We had completed records expectations. Do we want our physicians to have those completed records by end of day, by the end of next day? Okay, how much time would we want to do? E-medication orders, what is the percentage of all our medication prescriptions are done electronically? We measured that. We wanted to measure patient engagement. It's a harder thing to try to measure, but in fact, one of the performance metrics was that. When we talked about the 3 groups that we implemented, the first group being primary care, this is a slide that after 12 months, after the first year group, after the first group had been using this product for 12 months, the second group had been using it for 9, the third group for 6 months. And these were some of the things that we had. Encounters closed by 12 a.m. or by midnight of the same day. The first group was finishing those encounters at a rate of 78%. And amazingly enough, the specialists were at 89%. So the overall rate of encounters being closed was 83% by same day. It was 94% by next day. It shouldn't be at 100% because there are some circumstances where you can't really close a record without having seen some other information. But that's a pretty high rate, I think, of closed encounters by the next midnight. Medications prescribed electronically, we were at 80%. But one of the more curious things that we measured was mean time to last close was 5 p.m., median time to last close was 5:24 p.m. We heard a lot of noise from some of our physicians that in order to use this as a documentation tool, they couldn't go home at 5 o'clock. They couldn't go home at 7 o'clock. They were working until midnight, just about. And people broad brush those conclusions. But we were actually keeping score. We can keep score of when a specific provider closes their last record of the day. And our mean time to last close was 5 p.m. So that tells a story when it allows you to kind of get away from the broad brush, everybody's working till midnight and this is ridiculous, to, well, wait a minute, let's look at the facts. The facts are, okay, the mean time is at 5 p.m. Now, some people were closing much earlier than that, and some people did work till 10:30, 11:30, midnight, and that continues today. But when you peel the onion, some of that is local preference. I want to go home, I want to eat dinner, I want to do homework with my kids, and then I go to my computer and finish my records before midnight. So there's information that you can attain that helps you tell a story in defense of or in proactively making change. Okay. How were we going to do this? Well, we wanted to identify and mitigate challenges ahead of time. So gaining acceptance is the big thing, and that's what we're talking about here for the most part. But we also wanted to talk about the technology puzzle. You know, where we're going to use remote computers, thin clients. Was there a computer in every physician's office? Were we going to use things like nuances, voice recognition technology, or Dragon? How were we going to deal with physician adaptability? How were we going to identify the outliers, and what were we going to do about it? The implementation timeline, of course. Expectations, what were we expecting from everybody? What were we investing, were we tracking that, and how were we going to govern the whole process? I believe I get into the governance issue right now. What we did is we had a overlying implementation oversight committee, which basically was our CEO cabinet. There's 5 of us in the CEO cabinet, and we included some of our CMPOs. Most organizations call them CMIOs, Chief Medical Information Officers. We call them Chief Medical Process Officers. And we did that on purpose to identify the fact that we thought process trumped information in that argument. There's a play on words, I know, but when we come down to adaptability, process, I think, reigns over just about anything. And if we don't get the process correct, you're losing a lot of efficiency. So we dealt with that. We had an ambulatory subgroup of which we're now talking, and this group met regularly to deal with any escalated issues that came forward from our implementation team. So the implementation team would identify if there were any issues that they couldn't resolve on themselves. It got kicked into an ambulatory steering committee where it was discussed. It was usually resolved at this level, and if it couldn't be resolved at that level, it kicked into the oversight steering committee, and with enough information, that group actually called the shot, if you will, but we didn't have that many issues that percolated up to that level. This is another depiction of that. The EPIC project group, when these things related to a lot of the inpatient things, and I must add, we did not convert a practice management system on the ambulatory side. We simply converted the EMR. Our practice management system is outsourced to a company in Watertown, Massachusetts, but we are presently planning to transition from that. But this is another take as to how we tried to govern the project that we were dealing with. Physician leadership is very important, and this is a depiction of our chief medical process officers, and we actually trained 3 physicians to be builders on the platform, but these people were instrumental with bringing forward the message of change, managing that change, running interference with outliers that were needed management, if you will. So I attribute much of our success to these people on this slide, and it's very important that physicians can talk to other physicians. This is not something that's a secret. Everybody knows that. But Dr. Bengston and Dr. Dorsey right now are 2 key individuals as we move forward with innovation in optimization. Okay. I talked about issues percolating up the ladder, if you will. Well, when we did percolate things, or almost any decision we made, we insisted on a decision document, and that decision document tried to identify exactly what the issue was, what options we had for resolving it, we tracked through a formal process how we voted on these things. And so we developed this on our SharePoint project site and allowed us to track, manage, and communicate the decisions that we were making. So occasionally, the CEO cabinet or the steering committee, excuse me, seeing that there were not a lot of issues coming up the ladder, wanted a summary of what we were doing. And so this served the purpose. I was able to bring my SharePoint site up to talk about all the decisions that had been being made, and this served us well. Communication is obviously very important, and we developed a communication matrix in a formal communication subcommittee, and these were all the different ways that we attempted to communicate with our stakeholders, the frequency with which we would communicate, the method by which we would communicate it, and the purpose of said communication. I have to say that it probably wasn't perfect, but I was pretty well satisfied with the overall result, and I think that the level of communication, if you were to query my organization, I believe they'd indicate that they were pretty well apprised of almost every step we took. The click and the dead. I want to write a paper about this, but the reason I put this here is I talked about closing records by midnight and being able to measure that. Another thing that we just started is, we talk about click management. Don't add 3 more clicks to my day. We're actually doing some work right now in terms of how many clicks does a typical primary care doc have to use in order to jockey through a routine exam, and where can we eliminate clicks if possible. And when ICD-10 is introduced and we have to add clicks perhaps, it's not because of the EMR that we've added them. It's just a benefit of having the EMR that we're able to get that through. So I wanted to put that in there because I think that's an area of interest to me. Know your medical staff. We went everywhere with our message. We went to the medical executive committee meetings. We went to the medical executive committee dinners. We went to the medical records committee. We went to the annual dinner meeting. I just said that. We had a physician questionnaire. We had every opportunity available, but the one I wanted to stress is I met with every one of 140 physicians one-on-one, anywhere between an hour and 2 hours. And in that discussion, we just had a general discussion about, where are you with the EMR? Where are you with technology? Do you know any of these products? Do you hear your peers talk about these products? Do you hear your peers complaining about these products? What is the level of complaint? In some cases, they said, well, the hospital down the road did this. Don't you dare do that to me. Well, that was all valuable information as we attempted not to step on the same landmines that our competitors may have stepped on. The one-on-one individual meetings served me very well personally because in difficult moments, I was able to look at individual physicians and say, when I met with you, you told me this. And so I'd say that was one of the items in terms of change management that I thought served as a very good foundation for our success. Workflow, we talked about chief medical process officers. We attempted to workflow existing workflows and also using some lean processes here, identify who was involved in those workflows and how the introduction of the record might in fact change those workflows, so that when we had discussion about what they were, we were able to edify the stakeholders in terms of why they were and what the benefits would be. I talked about having engaged our physicians. Well, we did this survey, and there's a lot of training that needs to happen with our physicians, right? And those of you in the audience that have already implemented, you know that. But if you haven't implemented, there's a lot of discussion, there's a lot of training required. And so we asked our physicians, what kinds of training would be best for you? Nights and Saturdays, 3 4-hour sessions, 2 6-hour sessions, a summit, we're away for 2 days, those kinds of things. And these are the responses we got. So we leveraged this information in our design of our training schedules going forward. So if there's one thing that we need to emphasize here, it's communication. There's never enough of it. No matter how much we tried, it seems like, you know, there is the need for more. I ran into physicians that, despite all these efforts, said, well, I didn't know that and I didn't know this. And so that was difficult, so I had to remediate those kinds of things. But when we met with our physicians, we tried to relate to what I call the truth. Change is difficult. The EMR will probably not save you time, okay? The discussion I had about that timeline where an investment that a physician makes is for the benefit of everybody. That's a hard sell in some cases, particularly docs who are driving revenue through RVUs. There is a learning curve, okay, and it's a measured learning curve. Training is important. Don't poo-poo training away. Don't think that if you haven't done your EduNet sessions ahead of the formal training that would be of benefit. Training is important. There are benefits, documented benefits. They may not all be visible at first, but there are significant benefits to be had. And when you go through level 7 and you start talking about case studies and some of the cool things that we're able to do, you need to communicate those back to your physicians so that they understand what you were saying up front. It's the patient's record, not the provider's record. Performance can be measured, and over time, the system can be optimized. We can reduce clicks over time. We can demonstrate a benefit over time. And despite the noise from the current literature that I read about, that benefit should overwhelm the difficulty of changing. So with that, I'm kind of at the end of what I thought were the main points of our success leading to level 7. And I guess, Anthony, that I'd take questions at this time.
All right, very good. Excellent presentation, Dennis. As we mentioned, go ahead and send in any questions that occur to you and leave the default set to all panelists. We'll get those in front of Dennis. Question, Dennis. Was stage 7 something you have to get in front of the board in terms of getting sort of sign-off on as an objective? And was that difficult since there wasn't a direct monetary incentive?
No, the board didn't direct us to get to level 7, but it was an objective that I documented for our CEO, and it became an incentive item for the executive team and the organization. For example, this year, one of those incentive goals was to meet all the meaningful use requirements for stage 2, year 1 on the ambulatory side, stage 1, year 2 for the hospital side, and either a level 7 designation for the ambulatory or hospital side. So it was baked in to our formal incentive program. That is presented to the board, and the board now knows that we've met or attained them. It was not a hard sell. We sold the HIMSS Analytics 7 as a third-party independent view of our success, and so it was better than my going to the board and say, look, we met all these objectives. I was able to say a third party looked at it, and they are indicating that we're within 4% of all the ambulatory organizations that have attempted to do this.
Very good. You talked about trying to measure patient engagement. Can you give any more examples on how you did that?
Patient engagement, We talk about the after-visit summary as the main item in trying to engage our patients, but as you know, the vendor that we use has a pretty decent patient portal, and we're trying to optimize that, and we've tried to advertise that to patients. And our success rate in terms of total visits or total unique patients per year, we're not satisfied with how many people a lot of people activate their portal. The portal will work, but not a lot of patients actually go there very often. And for example, every time I have lab work, I get an email message that says your lab results are in your portal, and so I go there and and I suspect that a lot of type A patients would do that. So we are still in the process of trying to engage patients at a different level than simply looking at lab results, and we're banking on our portal with which to do that.
Very good. Did you do a baseline when you started this? The question is, what stage were you at when you started the goal of making stage 7?
Well, I don't know if we did that formally, but you know, we had all electronic ancillary systems in place. We had kind of a clinical data repository. We didn't have nursing documentation in basket things, and we didn't really have a way to do electronic prescribing. So we knew some of the deficiencies along the continuum, and so as we embarked on our journey of implementation, I can't tell you that each of the stage 7 requirements were in full consciousness, if you will, but they were somewhere in the background saying, you know, these are the measures of success going forward. For the longest time, I was tracking, because I'm kind of a loyalist HIMSS member, I guess, that my stage score was 4.347. It's kind of like pi. I knew that number by heart. Mm-hmm. And I said, why can't I move it ahead? And I couldn't move it ahead for certain reasons. And eventually broke the logjam and able to proceed to a 6-point-something score, leading to, I think I'm ready for a level 7 audit. And that's when we invited them last year to come in and do that.
Okay, very good. One more question before I let you go. You mentioned you've been at this since 1981, not to date you, but and you know, I'm sure a lot of things have changed since that time, but maybe some of the principles are consistent. What it's always taken to be successful in this type of role. Anything come to mind to over to your less experienced colleagues? Well,
Anthony, you're referring to my tenure as a CIO. I've been a CIO since 1981. You know, I had a slide here about communication. I think the CIO's ability to communicate at several levels, the executive team, the people in the trenches, the board, okay. I've been lucky. I've had access to my board for most of my career. Not everybody seems to have that, but I've been lucky enough to have it. And so being able to describe difficult processes and material so that everyone understands what's going on, I think, is very important. I guess the word that we could use on that would be transparency. What are you doing? Why are you doing it? Is very important to everyone. Everybody wants to jump a lot of what they consider a mundane task of getting to an objective. And I think that leads to a lot of misunderstanding once you get there, and people don't seem to be satisfied with getting there. So I'd say if there's anything I've learned over the years is building relationships with key individuals and making sure that you continue to do that. Let me add this. I've been here at Rockford for 20 years. I've worked with 3 CEOs. I've worked with 5 CFOs. I've worked with 3 HR VPs. I've worked with 3 different professional practice organizations or reorganizations, and I've worked with 4 COOs at the hospital. So I've survived a lot of change. And so not only has communication and relationship building been very important, but carrying an IT strategic plan is of utmost importance, because with every change, particularly at the CEO level, I was able to go to my new boss and say, here's our strategic plan, this is what we've accomplished against it, this is the remaining items on it, I reiterate or refresh this every 2 years, okay, do you agree, do you want me to proceed? That strategic plan, I believe, carried me through all these changes.
Excellent. Excellent advice, Dennis, and we certainly appreciate you presenting some of your story today. So with that, I want to again thank Dennis LaRue for participating, and we hope to have him again in the future. You'll receive an email when our archive is ready, usually within 2 business days, if not sooner, and a separate registration is required. For those of you who hold the CHIME CIO certification, attending our webinars gets you 1 credit for each event. If you've asked us to let CHIME know about that, we will. If not, go ahead and let CHIME know. Questions, comments, you can reach out to me, and you go to our website to see our upcoming schedule and our last 12 months of events. So again, I want to thank Dennis, our attendees, and everybody have a wonderful day. Thank you.